I forgot to record. Okay. Now you may go.
So I'd call the doctor's office, get
Ring, ring, ring. This is Dr. Duhan. Can I help you?
hello, Dr. Duhan. So our patient tested positive for strep and we need some medication for it to treat it.
Well, who is this?
Oh, this is Cindy Chubb, so-and-so's nurse.
Very good, very good. Okay, so they've tested positive for what?
Strep.
Strep, very good. How old is the patient?
35.
35, very good. Okay, well, I'm going to order for this patient to have I don't know the whole dosing for adults, so this could be completely wrong. That's a side note. I'm going to order 1 million units of penicillin to be given IM right now. Please and thank you.
Okay, perfect. I will administer the 1 million.
Thank you so much. All right, guys. So that was a great report. Thank you, Ms. Chubb. I'm giving you a round of applause for that. I appreciate you. So that was a great call to the physician. Remember, always identify yourself. Let them know who you're calling about, what's going on, and then we can go from there. But that was a great job. Strong work. All right. So if anything else was going on with that patient at the time, then you would let them know. So we've got those positive test results. So if your patient was running high fevers, complaining of terrible pain, those are things to let your doctor know as well, because they can also prescribe something else to give. All right. Very good. Any questions on that? We're all good. Okay. Very good. Moving on to the thing that I like to delegate over to the respiratory therapist is the sputum specimen. You may not always be able to delegate over to the respiratory therapist, so this is why we have to learn it. It's not my favorite thing to do at all. I can't stand to see normal people walking around coughing up things, so I definitely don't want to see it in the workplace, but it's our job, so we have to get used to it. Mind over matter, right? All right, so the purpose for collecting these sputum specimens is for cytology. We want to find out if there's any cancerous cells there. We also would want to do a culture and sensitivity so that we can find out what is exactly causing this person to be sick, so that we can figure out which antibiotics they're going to be most sensitive to. And then the acid-fast bacillus, which is the way that we can diagnose pulmonary tuberculosis. So this is a very common way. If you have a patient and they're suspected to have tuberculosis, first off, what kind of isolation are they going to be in? Anybody?
Airborne.
Yes. Was that you, Miss Medina? Yes. Airborne precautions, absolutely. So they're going to be in that negative pressure room every time we go in as nurse. Then that means that, yes, ma'am, Miss Johnson, I was just about to say that negative airflow room. And they will, we will wear what kind of PPE every time we go into the patient's room?
The N95 mask.
N95. Very good. Your N95 mask. All right. And gloves. And I would put on a gown as well. Yes. Yes. So make sure that, if that's your patient, that's what you're going to be wearing is your whole getup. Goggles if you need be. Okay. So this acid-fast bacillus test is something that they do for 3 mornings in a row. They need 3 negative reports before they can decide that your patient does not actively have tuberculosis. So I'll get into that in just a minute. A little more, right? Make sure, as with any other culture or a specimen that you're collecting, if you're doing a culture and sensitivity, whether it be urine, whether it be a throat culture, a nasal swab, sputum, wound, any of those things, make sure that you get the specimen before you start antibiotics, okay? All right, so if you're collecting the sputum by suction, you cannot delegate this to your nursing assistant, okay? Because that is that is something that is reserved for you, the nurse, to do. You cannot delegate that over. Oh. Excuse me. All right, where am I? What's going on here? I missed my pages up, guys. Okay, here we go. Also, I think this is the last retrograde for 2020. So if wonky things start happening, please get your crystals and put them around you. I'm pretty sure that's what's going on right now.
That is what's going on right now.
Mm-hmm. The interwebs are a mess. I mean, I'm forgetting things. So, you know, do all the things. Get your oils, sage, put your crystals on around the house, everywhere, and then we can be okay. Allegedly. All right, thank you, Miss Ralph. How long does this one last, Miss Ralph? Is this till November 3rd, right?
I thought this one just started.
It did. It did just start, and I think it goes until November the 3rd or the 2nd. Right around Election Day is when this thing is over.
Goodness gracious.
I know. Be a fence. Be a fence.
I just went outside yesterday and put my feet into the ground. I had to ground because it was so much. And I was like, Jesus, Lord.
Oh, anyways, this moment has been brought to you by all the people who believe in all the things, You're welcome. Moving on. All right, so if you're going to do a sputum culture or a sputum specimen, you're going to need, of course, like everything else when we do these, you're going to need to make sure you have identified your patient. Make sure you have your lab slip, your biohazard bag, because you do not want to be carrying around that in the hallway without it being in a bag. You'll need whatever way you're going to collect your specimen. So if you need a suction, there's a certain kind of suction equipment that you can use that will actually put the sputum into a little trap so that you don't have to do anything but connect the suction, then disconnect, discard the suction, put a cap on, and turn it in. Or you will have just a regular container if your patient can't expectorate their own sputum. Ugh. All right. What should our label contain? Anyone?
Name, date of birth.
Uh-huh.
Name of test and source of culture.
Very good. Anything else? Name.
The name of person taking the collection.
Miss Johnson, you're breaking up real bad. Type it into the chat for me. I feel like you said what I think you said, but I'm not for certain. Name of person collecting, absolutely. And did somebody already say date and time that it was collected? Those would be the last.
Yes,
So oh, you did say that? Perfect.
I was talking, but so
I see. And thank you, ladies. Those are absolutely correct answers. So always make sure that you have all of those things on your requisition or your label whenever you're getting ready to handle that for your patient. Where should we label our specimen?
Not on the list.
Name on the label, Oh, excuse me, name person, that's not what I'm reading right now. Before the specimen is collected. So I would do, yes, absolutely, in the patient's room, at the bedside, in the presence of the patient. Okay, thank you, Ms. Johnson. You always want to make sure that you label it in front of the patient so that you don't mislabel someone else's lab work. Okay, very good. Okay, moving on. If you're going to be collecting your sputum specimen by suctioning, then of course you're going to need a suction device and your suction catheter. This needs to be sterile because you don't want to have any other organisms on that catheter that could give your patient a false positive of some sort of organism, okay? So you'll need sterile gloves and clean gloves. You'll need sterile water. You'll need a sputum trap. And if your patient is on oxygen, you'll need to have it on standby, just in case they need it or if you need to turn it up. And please, whenever you are collecting anybody's sputum, make sure that you put on some sort of protective eyewear, because that stuff will come out flying sometimes and you don't want that in your eye. Trust me. It's never happened to me because I have these lovely built-in protective eyewear. Sometimes I wear my thicker glasses to work so I can make sure nothing, I'm covered. But if not, then make sure you put goggles on because you don't want that to fly up in your face. Okay. All right. Like we said before, always make sure that you're identifying your patient at least 2 ways. Review those orders to make sure that you have an order to do a sputum sample. Determine when the last time your patient ate. All right. You don't want to, is it a good idea to have somebody kind of cough up something after they've eaten? No, because it's not just going to be sputum coming up. It's going to be some other things. So just make sure that you've found out when the last time they've eaten or when the last time they had a tube feeding if they have a, if they're getting tube feedings, right? So it's best to get those specimens either 1 to 2 hours after they eat or 1 hour before they eat, all right? Because we don't want them to vomit and, especially our patients who aren't able to move as much, we don't want them to aspirate, right? So if your patient needs that acid-fast bacillus, the test that's going to determine if our patient has tuberculosis, then this is going to require 3 consecutive morning samples, all right? So the best time to do it is first thing in the morning, like right when the patient wakes up. So typically, our RTs would come in and do these tests around 6 in the morning, because if you think about it, when you lay down and you're sleeping at night, all those secretions will tend to pool, so you'll have the best sample that you can get at that time, okay? And that's where we're gonna find that bacteria. So the best time for us to get that acid-fast bacillus is first thing in the morning, because they've all accumulated, all that bacteria and all that sputum is just sitting there waiting to be collected. Sounds delightful, doesn't it? All right, make sure that you do a respiratory assessment on your patient, see how they're breathing. You don't want to do this if they're having difficulty breathing, okay? You want to let them catch their breath, give them a few moments, and then do what you need to do, okay? Let's see here. Make sure your patient knows what you're going to do. Don't just go in there and start trying to suction. It's not a good idea, okay? All right, so if we are going to do this sputum collection, some expected outcomes for us would be that the patient, for one, that the patient's respirations and their respiratory status is the same as before you started the procedure, okay? You want to make sure that your patient does not, their status does not decline just because you've had them cough or because you've had to suction to get a sputum sample, okay? If you have to suction, make sure if your client stays calm, because sometimes, not sometimes, but if someone is having to suction you, you tend to get a little anxious because it's not something that we're used to. So make sure that your patient, kind of stays calm. Make sure that we don't want that sputum to be contaminated by anything else in the mouth. So we only want that sputum. So, you're gonna have to suction closer to the back of the throat than you normally would, because you want to make sure you don't mix everything else in with that, okay? All right. Make sure that you are doing all of the things to ensure your patient's privacy, right? I'm a lady, I'm a Southern lady, so if you need a sputum culture from me, I can't have anybody else knowing that I know how to spit up sputum, okay? Because that's just not okay. I don't want anybody to know that's me behind the curtain. So give your patients that same courtesy and make sure that they have privacy that they need. Okay. I mean, I'd probably go all out as to tell my nurse, hey, listen, can you turn the radio on so nobody hears me doing this? Like, it's something that I just don't feel is ladylike. So anyways, so make sure you provide privacy for your patient. Make sure you tell them what to do. Tell them to breathe normally while you're suctioning so that we don't have any hyperventilating, because that's not okay. All right. As before, I think it was last week, we said if your patient's going to have any kind of suction, make sure, hopefully you have made sure that the machine works before the patient went into the room. If not, double check and make sure that your suction canister is working well right now before you go on to suction. All right. Remember how we said once upon a time that your patient gets the best lung expansion if they're sitting upright. So if they're sitting in semi-Fowler's or high Fowler's position, it helps to get their lungs expanded better. That's going to give you a better ability to cough. So make sure your patient is sitting up and not lying down when you're wanting to get the specimen from them. Okay. Let's see. Want to make sure we let them rinse out their mouth with water before we do this. Don't let them use regular mouthwash or toothpaste. This isn't the time to get their mouth right. Hopefully we're wearing a mask when we do this anyways. So if it's 6 a.m. and your patient has dragon breath, then so be it. Tell them, put them at ease. It's okay. I just need you to cough this up, and then I'll let you brush your teeth afterwards. Okay. Those toothbrushes, or not toothbrushes, but the toothpaste and the mouthwashes and things, they can alter your results of the sputum testing. So be sure that they don't do that prior to you doing that. All right. Have your patient take 3 to 4 slow breaths with full exhalation before they do this. And then they'll take 1 full inhalation followed by immediately coughing. Okay. And that will give you, or that should give them, a nice amount of sputum. Okay. And they were going to cough that right into the container. Okay. You're going to need about 5 to 10 mLs of sputum for the best sample size. Okay. So it's 5 to 10 mLs is what you're going to need. And lucky for you, I have a video. So I'm going to show you, because I know you guys want to see this first thing in the morning. And some of these videos that I'm showing you guys, you don't have access to, so that's why I want to make sure I show them now. And then for tomorrow's lab, I will show, I think, collecting a urine specimen, because that's what we're doing for lab. And then I'll do the glucose one again if you guys need it, but I'll do that later today as well. So here we go. Let me share my sound.
A sputum specimen can be collected in one of 2 ways, by expectoration or by suctioning. Start by checking the healthcare provider's orders to see which collection technique is to be used, how many specimens are needed, and when they're to be collected. After performing hand hygiene and ensuring privacy, introduce yourself to the patient. Then identify him using 2 identifiers.
Please tell me your name.
William Turner.
And your birthday.
3/16/47.
Okay, thank you. What we need to do today is get a sputum sample from you. I'll be back in just a little bit with some supplies.
Okay.
Then assess the patient's respiratory status and anxiety level.
Again. Sounds good.
Give the patient an opportunity to rinse his mouth with water. He shouldn't use mouthwash or toothpaste before specimen collection, because doing so may alter the results of the specimen culture. Apply clean gloves. To collect a specimen by expectoration, give the patient a sputum cup and instruct him not to touch the inside of the container. Ask him to take 3 or 4 deep, slow breaths, exhaling fully after each one. Then coach him to take a full inhalation followed immediately by a forceful cough, expectorating the sputum directly into the specimen container.
3, cough.
Ugh. Ugh. Ugh.
Now we're going to repeat that. We're going to do it again.
Repeat this process until you've collected 5 to 10 milliliters of sputum, not saliva. Before you collect a specimen by suctioning, position the patient in a high or semi-Fowler's position. Prepare and turn on the suction. Then connect the suction tube to the adapter on the sputum trap. Open the bottle of sterile water and pour the water into the sterile container. Apply a clean glove to your non-dominant hand. Using sterile technique, apply a sterile glove to your dominant hand. If the suction catheter has a plastic sleeve, you can use a clean glove instead of a sterile one. With your sterile hand, connect the sterile suction catheter to the rubber tubing on the sputum trap. Make sure the suction valve is off and lubricate the end of the suction catheter with sterile water. Warn the patient that the catheter will probably trigger her cough reflex.
It may trigger your cough reflexes, which is exactly what we want.
Gently insert the tip of the suction catheter into her nasopharynx or advance it through the patient's endotracheal tube or tracheostomy tube. Again, the suction valve must be off during this step. Quickly and gently advance the catheter into the trachea. As she coughs, begin to apply suction. Continue for 5 to 10 seconds, collecting 2 to 10 milliliters of sputum. Then release the suction valve, remove the catheter, and turn off the suction. Offer the patient some tissues.
Tissue for you.
Remove the suction catheter and the tubing from the sputum trap, and dispose of the catheter in the appropriate receptacle. Then connect the rubber tubing on the sputum trap to the plastic adapter. Whether you've collected the specimen by expectoration or by suctioning, note the characteristics of the sputum. Include its color, consistency, odor, volume, viscosity, and the presence or absence of blood.
I'll pause right there so you guys can write that down so that you know, just in case I ask you, what you need to tell me if you're reporting this off or if you're documenting. You need to make sure you let someone know the color, the consistency, if there's an odor, how much you are able to collect, the viscosity, and the presence or absence of blood. This video is tough to watch, guys. All right. You guys ready for me to go on? Very good.
Tightly close the specimen container. If there's any sputum on the outside of the cup, clean it with a disinfectant wipe. To finish preparing the specimen in the patient's presence, attach the label to the side, not the lid, of the container. Place the specimen in a small plastic biohazard bag or other container specified by your agency, and attach the laboratory requisition form to the bag.
Here's your call light. Let me know if you need anything.
Thank you.
Immediately send the specimen to the laboratory for analysis or refrigerate it for later transport. Now remove and dispose of your gloves and perform hand hygiene. As part of your follow-up care, offer the patient oral hygiene and review the results of the sputum test when they come back from the lab.
All right. Any questions on collecting a sputum sample? Either by expectoration or via catheter? Very good. Very good. All right. We'll go back to where we were. Oops. Oh boy. What did I do? Okay. All right, we skipped a few slides because we've kind of we went through all of the things with our video as well, and it makes more sense to see it done than for me to explain it to you, right? So if we've got our patient and we're doing our expectorating or collecting our specimen by suction, what we don't want to happen is for our patient to become hypoxic, okay? If that happens, whether your patient is actually doing the expectorating or whether you're suctioning, stop what you're doing and give your patient some oxygen so that they can catch their breath, okay? If they continue to be anxious, make sure that you stop what you're doing, let them calm down, let them get stable, let the provider know, and monitor your patient for a little bit, right? We want to make sure that we're not causing more harm to our patient than good, and they may have to just get the culture or the specimen at a later time, right? If your patient is post-op, they've just had surgery and you need them to cough some sputum up, make sure you have them splint the incision and cough that way, all right? If this is the case and your patient has had surgery, especially some sort of abdominal surgery, then you want to make sure you give them pain medication before you start doing this, because it could cause them pain if they have to forcefully cough, okay? All right, make sure that you're checking the patient's respiratory status while you're doing this. When they're taking those deep breaths and coughing that stuff up, you really need to monitor how they're doing, because sometimes that could get them, they could become hypoxic, or, you may notice, they might start turning a little blue, something like that. So make sure you're monitoring your patient while you're doing your job, all right? And like we said, once you're reporting off, or once you're documenting, you want to observe the character of the sputum, make sure that you've noted the color, the consistency, any odor, the volume, viscosity, and presence of blood, okay? If your patient is alert and awake, make sure you let them know the results of that testing. Well, I say that with a bit of caution. If there's something wrong with your patient, then you're not the one who needs to tell them, okay? So that's because you get yourself into all kinds of trouble. The patient's going to know, oh, why, what happened? How did I get this? How do we fix it? And, that's above my pay grade, all right? So if there's something wrong with the patient with those results, then you'll always want to let the doctor know, and the doctor should be the one to come and let them know, okay? If the results are normal, then by all means tell them, oh, everything came back fine, okay? All right. Once again, make sure that you are documenting exactly what you did and what happened, and then please report off to the next nurse what happened. So on that note, who didn't report for me? Miss Kyla Williams, how are you doing today?
What you said?
How are you doing today?
Oh, good. How you doing?
Oh, just living the dream. So I want you to give me a handoff report on a patient that you just collected a sputum specimen on.
Give it to you?
Yes, ma'am. You can make it up as you go. It doesn't have to be, just make up your patient as you go. It's fine.
I don't know. I'm just telling you like what I find in his specimen.
So just tell me, just let me know what you did, what you received from, what the patient coughed up, how they tolerated it, and that you sent it to the lab.
Oh, I don't do that.
You can do it. I promise you can do it. It's okay.
Okay, nobody paying me attention. I don't know how to do that. I collected the patient's specimen.
Okay.
He did okay tolerating it.
Okay.
I found very little blood in his specimen,
Okay.
and I sent it off to the lab. Oh,
Wonderful.
hold on. The consistency was normal, no odor, and the color was normal as well.
Okay. Okay, that's good. That's a good start. See, you was worried for nothing.
No.
So that's a great start. I know you guys, I don't expect you to be able to give like the most bang up report ever. This is the first time we're doing it. So this is a great start, okay? So, it's just like talking to, each other. Have you ever been a babysitter before?
Uh-huh.
So when the parent comes back, do you kind of give them a little report on how the kids acted while they were gone?
No, not with babysitting, but when I was working at Kids the Kids, we used to do that in the classroom.
Wonderful. So it's the same thing. So you just kind of give me a little synopsis of what happened with that patient.
Mhm.
So, patient expectorated 10 mLs of sputum. Instead of normal, and you can use terms like normal if it's a patient that you had for a few days, the next nurse has had that patient for a few days because we know that patient's normal. But otherwise, I would say, sputum was yellow tinged, frothy, no foul odor, small amount of blood noted. Let's see, patient tolerated well. We didn't need to give any oxygen afterwards. And it has been sent to the lab. So you might want to check, your lab results within the hour. Right? So very good. Good job. Good job. He was worried for nothing. All right. So now we moved on to collecting wound specimen. Any drainage from a wound. Guys, I don't know if anybody's excited about wound care. I love wound care. I think wound care is just like it does something to me as a person when I see a wound and I know that I had a hand in helping that wound disappear. Right? I love to see those things. Now, mind you, I haven't had a wound that was so terrible that I couldn't stand to be in the room. I haven't had those kinds of wounds yet, but I've heard of them being in existence. But I love wounds. So, but sometimes those wounds get infected, and we need to know what's going on with those wounds. So your doctor will order a culture, a wound culture. And like I said to you guys yesterday, the same Q-tip culture that we're using to get a nasal swab or that we're using to get a throat swab, those are the same things that we're going to be using for collecting a specimen from a wound. Okay. So we need to do these. Why are we doing the culture?
To do with causing the infection?
Absolutely. We need to find out what's causing the infection. All right. So we find out what's causing that infection, and then we need to figure out what medication we need to give this patient that will help this infection go away. Okay. Sometimes you'll need to do multiple wound cultures to make sure that your treatment is being effective. So that sometimes will occur if you're collecting those specimens. Okay. All right. If you have a patient who needs a wound drainage specimen, you cannot delegate that to the nursing assistant. Okay. The only thing that your nursing assistant can do for you in this instance is if they notice that that wound has a foul odor, if there's an increase in the drainage, or if the patient gets very uncomfortable, like that wound becomes very painful, or the patient has a fever. Okay. Those are the things that your nursing assistant can do for you. They cannot collect the specimen themselves. Okay. So if you're going to be collecting this wound specimen, you're going to need to make sure that you have the culture tube and the swab. And you'll need to know exactly what the doctor is wanting you to culture, if it's something closer to the surface or if it's a wound that's very deep. You'll need to know which kind of wound this patient has. Okay? You'll need to have your a syringe and a needle. That's not to poke in the patient's wound. That's more to clean it out before you start. All right. You're going to need several pairs of gloves. This tells you 2 pairs. I like to make sure that I have a nice supply of gloves when I go in and do this, because you don't want to contaminate anything where the wound is concerned. All right. So you'll need to have some clean gloves, and then you'll need to have some sterile gloves. Please put on some protective eyewear so that there's no chance that this is going to splash up on your face or anywhere. If you are doing a wound culture of your patient's wound and it is a draining wound, your patient should already be on what kind of precautions?
Contact isolation.
Absolutely. Your patient should already be on contact isolation. So that means that when you go in there into that room, you should already have a gown on anyways. You should already have your gloves on when you get in there. So you want to make sure that you protect yourself from whatever is growing in that wound, okay? Make sure you have some sort of dressing materials, because when you do your drainage specimen, when you go to get that specimen, it's a good time to go ahead and change the dressing for that wound. All right, so just have everything that you're going to need for the specimen and for wound care when you get in there. Make sure you have your lab slip, your label, your container, your biohazard bag. All right. Just like everything else, we want to make sure we know who our patient is, identify your patient, make sure that you're reviewing the patient's order. And then we're going to see if the patient needs an aerobic or anaerobic culture. And that is because if the wound is superficial, then it'll just be an aerobic, because you have more oxygen growing up there closer to the surface. But once it becomes a deep wound, you're not going to have the oxygen circulating around. So you would need an anaerobic culture. Okay. Make sure whenever you're doing a wound dressing change, it is really a good idea to go ahead and pre-medicate your patient. So if you know that you're doing a dressing change at 10 a.m. on your patient, please give them something for pain 30 minutes before you start. Okay. It's really kind of cruel to do wound care without making sure your patient is at least, their pain has been controlled a little bit. So please make sure you do that, and make sure that pain medicine is taking effect before you started, because these dressing changes and wound care and things, they can be painful. Okay. All right. Make sure you determine the dressing change schedule. So if your patient, let's just say, your patient's dressing change is due to be done at 9 a.m. and 9 p.m. So your doctor orders a wound culture at 7 p.m. Is it a good idea to go and undress that dressing at 7 p.m.?
No.
No, it's a better idea to wait until that 9 p.m. to get it done. All right, and then you just need to let your doctor know if they order it. The cultures are going to take, sometimes they take a while to come back. They might take up to 24 hours to get back. So, or the results to come back. So in that event, it's not going to make a difference really if I do this culture at 7 or at 9. So just make sure that your provider is aware that my next dressing change isn't due until 9. So I will do the wound care or the specimen when I do the wound care. Okay. All right, we are expecting that our wound culture does not have any bacterial growth. We're expecting that culture swab has not touched any of the skin surrounding that wound. We want to make sure that we're only getting a swab from the wound. Okay. We want to make sure that our patient has not gone into worse pain than what they had before we started. So we want to be sure that we have pre-medicated them before we start doing anything. And we want to make sure that we tell our patient the reason why we're doing the wound culture. Okay. That helps your patient to feel better. We just want to make sure there's no nasty bugs growing in your wound that we don't need to give you medication for. Okay. Tell the patient they may feel a little bit of tickling sensation. I don't know that it tickles all that much, but just let them know that they're going to feel it. And please give your patient privacy. especially depending on where the wound is, but make sure you give privacy. So if I just close the patient's door, is that all the privacy that I need?
No,
Why not?
because someone could open the door and then they're exposed again. You need to close the curtain too.
Absolutely. So if your patient needs privacy, or you're doing some sort of procedure, or if they've got a bedside commode going, it's fine if you close the door. But guess what? Most people who are looking for a nurse care less what's going on behind that closed door. So they're just going to open the door and leave it open while they're looking for you. Okay. And if that's the case, then your patient's on the bedside commode, or they have a wound on their buttocks and their buttocks is facing the door, then you've just given everybody in the hallway a show. Okay. So make sure when you come in the room, yes, close the door, but also close the curtain so that if somebody opens that door, your patient's just not giving everybody a show. Okay. Strong work. Thank you, Miss Ralph. Appreciate you. Okay. Make sure you do your hand hygiene. Remove the old dressing after you put your gloves on. Assess the wound, make sure there's no tenderness, and then check for drainage, right? Once you've taken off the old dressing, change your gloves, okay? You're gonna perform your hand hygiene and change your gloves. Right? Right. Then you'll want to clean around that area with some sort of either antiseptic swab or some sterile saline or whatever your doctor has ordered. Right. So what this does is it's going to remove all of the old wound stuff, like all that exudate, all the extra, all the crusties, all the extra wound things that we don't need. That's going to get rid of that as long as you clean it first. So you can irrigate the wound with saline. That's what you can use your syringe for. Irrigate that wound, get rid of all that old exudate so that you're getting as fresh of a sample as you can get, okay? Once you're done cleaning the area, make sure you take those gloves off, throw them away, and then you want to put on your, you want to open up your packages for the sterile cultures, okay? Open those packages, then put your sterile gloves on. And then if you're taking a swab from, or for aerobic culture, you'll insert the tip into the wound wherever the drainage is, and you'll kind of rotate that swab gently, okay? And then you're going to put it back into the tube. If it's an anaerobic culture, you're going to swab deeply into whatever is draining. So if you have a deep wound, this is what you'll do. And your culture swabs will be labeled appropriately, depending on which one you need, okay? If there is a super deep wound, I suppose, you can put the tip of a syringe into the wound and you can aspirate 5 to 10 mLs of that exudate if there's that much there, okay? Right, and if that's the case, then you're gonna use that needle to put that into the culture tube, right? Once you're done, you will take your gloves off. And while you're sitting there in front of the patient, make sure that they that you've labeled it. If your patient is receiving any antibiotics, because sometimes that's the case when your patient has wounds, make sure you make a note of that as well. Okay. Make sure you clean the wound back up and put on a new dressing, however you've been told to dress that wound. Right. I believe I have a video of the wound as well. Let us see. I do not. Well, it was a nice try. I don't think I do. Let me double check. So if we have a patient who has a wound and you went and got that specimen and you need to document that specimen, someone tell me what you got. Let's see. Miss Singleton, you there? Singleton. There you are. All right, so if you are documenting your patient's that you collected a specimen from the patient's wound, what would you document?
If I collected a specimen from the patient's wound, what would I document? I would document the color, the consistency. I would document how the patient tolerated it, stuff like that.
All right.
All right.
Very good. Very good. So yeah, she's right. You would document that you remove the old dressing. You cleanse the wound prior to obtaining your specimen. The specimen was obtained in using sterile technique. Specimen sent to lab. Dressing replaced. Patient tolerated with minimal discomfort. That's the kind of things that you would say. So good job. Thank you, ma'am. And lucky for you guys, before we go to the break, I have found a video for the wound. So I will show it to you so that it might make a little bit more sense.
After performing hand hygiene and ensuring privacy, introduce yourself to the patient. Then identify him using 2 identifiers.
May I see your wristband? And would you tell me your name and date of birth?
Philip Reynolds, June 25th, 1935.
Good, thank you, Mr. Reynolds.
Before collecting a wound drainage specimen for culture and sensitivity testing, assess the patient for signs and symptoms of infection, such as fever, chills, and excessive thirst. Ask him to rate his pain at the wound site. Apply clean gloves and remove the old dressing. After you've assessed the bandage for drainage, fold it together, soiled side in, and dispose of it in the appropriate receptacle. Now remove your gloves and apply sterile gloves for assessment.
Right.
Assess the wound by looking for swelling, separation at the edges of the wound, inflammation, and drainage. Cleanse the area around the wound edges with an antiseptic swab. Wipe away any old exudate. Discard the antiseptic swabs. Remove and dispose of your gloves and perform hand hygiene. Then unwrap the sterile culture tube and apply a new set of sterile gloves. To collect a specimen of aerobic bacteria from a wound, remove the swab from the culture tube. Gently insert the tip of the swab into a part of the wound that has fresh drainage. Rotate the swab and return it to the culture tube. To obtain a specimen of anaerobic bacteria, remove the swab from a special anaerobic culture tube. Insert the swab deep into the cavity of the draining wound and gently rotate it. Then withdraw the swab and return it to the culture tube. An alternative method of obtaining a specimen is to insert the tip of a needleless syringe into the wound and aspirate 5 to 10 milliliters of exudate. Then attach a transfer device to the syringe, expel the air, and inject the drainage into an anaerobic culture tube. Regardless of which method you use, be sure to label each specimen tube and verify information in front of the patient. Make a notation on the label if the patient is receiving antibiotics. Place the specimen in a biohazard bag, remove your gloves, and dispose of them appropriately. Perform hand hygiene. Apply clean gloves and clean the patient's wound if required by the healthcare provider's order. Open the dressing supplies and cover the wound with a new sterile dressing. For more information, refer to the video skill, Changing a Dressing. Remove and discard your gloves and dispose of the soiled supplies in the appropriate receptacles, according to your agency's policy. Perform hand hygiene. Help the patient into a comfortable position. Send the specimen to the laboratory immediately. As part of your follow-up care, review the culture and sensitivity test results when they come back from the lab.
Alrighty. Any questions on doing your one? Yes.
Can I ask a question?
Sure.
On the one right there where she was reaching off of her, well, like I guess her sterile area where her gloves were coming from, to grab the tube. I mean, isn't that contaminating what she's using?
Yes.
Gloves.
I'm glad you said that, because when I was watching this video, I was like, oh, wait a minute. She completely she opened the package that she had already touched with her sterile gloves and then proceeded to use that as if it was a sterile thing that she was doing. So best practice, if that's what you have to do, I would go ahead and open that package first and then put your sterile gloves on, and then you can grab that swab.
Okay. I was just saying, like, what the heck?
Indeed. I caught it too. Strong work. Strong work on that. All right. So I have 10 o'clock. Let's come back at 10:10.
Damn.
Alrighty, everybody come on back, sign into the chat for me, please. Oh, excuse me. All right, everybody back and signed in to the chat for me. Make sure we're all live on camera. Where's my chat button? There it is. Alrighty. So when we're collecting our wound specimen, our wound drainage specimens, we want to make sure that we're monitoring those results, because we need to know if there is any heavy bacterial growth with those cultures, okay? We need to make sure that we notify the provider and monitor our patient. So if our patient has a whole lot of bacteria growing in their wound, what kind of signs or symptoms might we see, like signs and symptoms of infections might we see on our patient?
A lot of pus. They may have a fever.
Absolutely. They may have pus coming from the wound. They may have a fever. They may have chills. If we're looking at their lab work, they may have an increased white blood cell count. And so for any of these things, we need to make sure that we let our providers know what's going on. All right. Oh, what's going on here? Right. So make sure we let our provider know and we monitor our patient. Right. If our patient reports an increase in pain, make sure that we're giving them pain medication for that. And let the provider know, hey, we've got some increased pain. Tylenol's not cutting it. Is there anything else that we can get for this patient? Okay. All right. Once you're done collecting your specimen, you record the type of specimen that you obtained, whether it's an aerobic or anaerobic specimen that you've gotten, the source. So we know it came from a wound, so don't just say that specimen obtained from wound. Right? Your patient may have multiple wounds. Let's just say your patient was in a car accident and they have wounds everywhere. So you need to be as specific as possible. So specimen obtained from wound to right shoulder. Okay. Just be as specific as you can so that we know exactly which wound that we're looking at here. Okay. Make sure you time and date it. You want to let us know the appearance of the wound and any of its characteristics, and how the patient tolerated it in their response to any pain medication that you gave. So if I obtain a wound specimen and I'm going to document it, then I would say, I date and time what I'm going to document. So what time is it? Today is October 14th at 10:13. I should wait until 10:14 on 10:14 to make my note. Anyways, so I would chart that wound care provided to wound to patient's right shoulder. Wound is, this is a great time to get out your disposable tape measure so that you can measure the wound. Wound measures 14 centimeters and is, let's just give it 5 centimeters deep. Okay. Wound area around wound, skin around wound cleansed with whatever you used. Let's just say sterile saline per order prior to obtaining specimen. Aerobic specimen ordered, so that's what we've given. And then we'll obtain our specimen, wound cleansed at this time, and wound care provided, wound redressed, specimen labeled and sent to the lab, patient tolerated with minimal discomfort as they were pre-medicated with whatever medication they were given 30 minutes prior to the dressing change, right? So you just report that. And then of course, If you have a nurse that you're reporting off to, you will be giving them report as well, okay? Letting them know that you have obtained the wound. Like I said, sometimes those cultures take about 24 hours to come back. And so you want to make sure that you tell the oncoming nurse, this is what I did. I changed the dressing at 9 o'clock. And then I gave pain medication at 8:30. And the wound specimen was sent off today at 9:15. And so the results probably won't be back until tomorrow at the same time. So make sure you let them know, because sometimes, does a specimen include measuring the wound, or is that just wound care? That's just wound care. So if I'm doing wound care, before I dress it back up, I want to know how big that wound is, because sometimes one of the ways that you can see that the wound is healing is that the size will decrease. All right. Did that answer your question, Ms. Johnson?
Can you repeat that, Ms. Dula?
Sure thing. So the specimen, actually just doing the specimen does not include measuring the wound. But since you've got the dressing open and you're looking at the wound, it's a good time to do all the things related to that wound while it's open. Otherwise, you put the dressing back on and you can't see anything else.
Yes, that does answer my question. Thank you.
You're welcome. All right. Moving on, any questions on wound care? All right, now we're going to go do some blood glucose monitoring. For our skills lab tomorrow, and for Friday when you check off, well, for Friday when we check off, we don't have to, but for tomorrow, I want you guys to actually practice on each other for real. So we're going to be poking each other tomorrow. All right. I know, Miss Johnson, it's okay. I promise you it's okay. I did it myself. I practiced on myself last week to make sure that the things was working properly. And I will tell you, we're using the same equipment that they would use in the facility. Most patients have their own lancets, and so theirs may not sting as much as ours might. So just be prepared. We're just gonna let each other do it one time. It should only take one time for you guys to practice on each other. So, okay. Oh, you don't want to hurt anyone. You are such a good nurse. I promise. You're gonna make a great nurse. But listen, we gotta hurt people sometimes. So I know you don't want to hurt anybody, but it's only for a split second that they'll feel the pain. And then it might not even hurt. Everybody might have a high tolerance to pain, so they'll be fine. But we are going to practice on each other, because it does feel, it gives you a good feel of what you're supposed to be doing when you check someone's glucose. Okay. Right. So if in fact you do have the diabetes, or you're borderline or something like that, just kind of let us know so that we're not looking at your blood sugar and trying to rush you off to the emergency room. Okay. All right. So what's the point of doing blood glucose monitoring?
Making sure that your diabetic patient doesn't have any problems, because having high blood sugar causes a lot of different physical problems. Like your homeostasis, for one, can be off because of it.
Lots of things can be off because of it. So absolutely. So we want to be checking our patient's blood glucose because we want to assess how they're controlling their diabetes.
They could be in they could fall into a diabetic coma or something as well.
Exactly. Their blood sugar could be super high, or it could be super low. So we want to make sure that we're checking their blood sugars, and the doctor will prescribe how often it's to be taken. But we're to be checking them so that we can monitor how they are controlling their diabetes. Are they following the diet? Are they using their insulin appropriate? Things like that. Right. So nowadays, and you guys will learn all these things whenever you get to endocrine system with, I guess med-surg. I don't know if it's med-surg 1 or 2, but you want to make sure that your patient knows how to use their equipment. So most times, if they're newly diagnosed, there is usually a diabetic educator in the facility, or the doctor will send them to a diabetic educator, and they will teach them all the things on how to use their glucometer themselves, right? Because if you don't know how to use a glucometer and you don't know how to check your blood sugar, then you're not going to do it right, okay? We want to make sure that they're doing them correctly. Nowadays, we're pretty lucky. There's glucose monitors that take a very minimal amount of blood. So, you know, we don't need to do a deep finger stick anymore just to get a little tiny drop of blood. Some of them take like, you know, 0.3, as little as 0.3 microliters of blood, which is a tiny bit. So if you have a patient who doesn't bleed very well, then that is a perfect little machine for them. All of our machines are pretty small nowadays. They're not big dinosaur looking things anymore. They're lightweight. You can take them everywhere. And then of course we do have patients who, especially type 1 diabetics, who have their own continuous glucose monitoring as well. We won't get into that during this class because there's no need to. We're not going to do anything with our patients that have continuous glucose monitoring. That's something that they control, you know, on their own. So we'll just talk about using our little bitty glucose monitors. Right. This is the glucose monitor that we'll be using. If it's not this exact one, it's one that's very similar to it. And like I said, there's many different types of them. But basically they're going to come with, it's the unit itself, the glucometer itself will look like this. They typically turn on by themselves once you insert the testing strip, which is right here. And then this is the amount of blood that it requires, right? So once you poke your patient, a little drop of blood will get on their finger. You put this little machine or this little testing strip that's already inside the machine, you put it up against the patient's skin where the blood is coming out, and then the blood just kind of gets siphoned into this little opening here. And then it gives, they're super fast nowadays. They used to take forever, but now they take, I haven't seen them taking more than about 3 seconds, 3 to 5 seconds to read, and then you get your reading. All right. In some facilities, the CNAs can do blood glucose monitoring. Are you guys allowed to do them now? Good, good. It's not incredibly hard to do. The most important thing, if you have a CNA that is gathering your glucose monitoring for your patients, you need to make sure they know to let you know what the numbers are. Okay. So what's going on with my chat box here? Sorry, okay, there we go. In the hospital they do? Very good. Very good. Right. So this here says during an acute illness, so let's just say your patient is, they're going into diabetic ketoacidosis, which is bad, or their blood sugars are super low and they can't be stable. If your patient is not stable, right, they're newly diagnosed diabetic, they're an uncontrolled diabetic, their blood sugars are super low, then the CNA cannot do the glucose monitoring, okay? If the patient is stable, so like if you're in a skilled nursing facility, a nursing home, something like that, your patient is stable, they're not expected to change, then depending on your location, the CNA can be allowed to obtain those blood glucose levels, okay? Just make sure that they know, if you're that nurse taking care of that patient, make sure that your CNA knows the appropriate site for using, for puncturing when getting those glucose levels, and knowing what the expected blood glucose level is and when to report it, okay? So make sure that your nursing assistant knows these things so that you don't get into trouble because those things weren't reported, okay? Because ultimately it is still your patient. You are still responsible even if someone else were to check their blood sugar, okay? So you're gonna need an antiseptic swab, a cotton ball, you'll need the lancet, and most facilities have their own brand of lancets. They'll have their own stash of whatever lancet they use. They do not, you cannot adjust the depth that they are injected or used. So determine if your patient has their own lancet devices, because they can use whatever depth works good for them. I think mine I had gestational diabetes, and I think my Lancet, I could set it for, I think it was 5 different levels. 1 being like barely a mosquito bite, and 5 being going a lot deeper. So I had to make sure that I could get blood off of the level 1, because I didn't want level 5, right? So just determine with your patient if they have their own, because they're much more comfortable than the ones that we use that is supplied by our facilities. Okay. Make sure you have the blood glucose testing strips, and make sure you have clean gloves. And most importantly, make sure that you have your receptacle for throwing away these supplies is nearby. All right. You want to make sure that you're disposing of your glucose strips that have been used, and the Lancet itself. Anything with a needle, those need to go into the sharps container, the biohazard container. Right? Don't throw anything with blood on it in the regular trash can. Those need to go where you throw your Lancet. Okay. Right. And I'll show you guys. You may not have noticed them because they're just kind of at random, but we have them in the lab so that we can dispose of our equipment properly.
There was stuff in the sharps container when me and Nurse Jackie was checking off, and it was definitely not sharp stuff. It was
Are you
like,
talking about the one with the water bottle?
yes.
I don't know who did that, but I was wanting to fuss, and I didn't know who to fuss at.
Yeah, Nurse Jackie was like, I thought we were supposed to have somebody that came in here and cleaned everything up.
Indeed. So I'll take care of that tomorrow morning when I get there. Side note, tomorrow, guys, if you were unsuccessful in any of your skills last week, please be prepared to come in early tomorrow so that you can practice, and then retest on Friday. So you don't have to come in at 7:30 in the morning or 7 o'clock in the morning, but you need to come in earlier than your scheduled time so that you can practice whatever skill you missed, okay? Very good. All right, back to Jack. So when we're getting ready to do our blood glucose checks, please make sure you have the correct patient. If you're in a nursing home, I mean, there's a lot of patients sometimes that need their glucose checked. Please make sure you have the right one, because if you go and tell the nurse, or well, you are the nurse, but if you forget to identify your patient and you go into the room that houses 2 patients and they both get their blood glucose checked, and you mix up your numbers, then you might end up giving Miss Louise over here 5 units of insulin when she didn't need any. Okay, so make sure that you're identifying your patient. Make sure that you're writing it down or recording it as soon as you get it, so that you don't make a mistake and give someone insulin when they don't need it, or that you're not treating someone who needs to be treated. Okay. Make sure you're reviewing those orders to make sure that you know when to check those blood sugars. Most of the time it's before meals and in the morning when they wake up sometimes, and then before they go to sleep. If they're acutely ill, like if you're in a hospital setting, if they're an unstable patient, then we also do a check at 2 in the morning. Okay. So just make sure that you review those orders to make sure when you're supposed to check those blood sugars, because you're not supposed to do it more often than what is ordered. Now, if your patient has an emergency, let's just say Miss Louise was sitting up in the chair, she's fine, and then you come back in the room 5 minutes later and she's slumped over, it's probably a good idea to check her blood sugar. Okay. So that you wouldn't need an order for, because we know she's a diabetic. Maybe her blood sugar is too low, or maybe it's too high. So you want to make sure that you're checking at those times in times of emergencies. But typically you just need a doctor's order for when you're going to do those blood sugars any other time. Okay. Make sure that any specific conditions are met before and after your samples are given. So make sure if your patient's blood sugar is being checked that that you need to eat, or they'll need to have some insulin, or if their blood sugar is too low, that they need to have some glucose or something sweet to eat, or a complex carb. So make sure that you're determining those things as you go. And then make sure you check and see if there's any risk to performing those skin punctures, right? So if your patient is on anticoagulants, if they have any bleeding disorders, then it may be pretty hard to get them to stop bleeding once you puncture their fingers. Okay, So you need to make sure that you find that out beforehand so that you're prepared to deal with it afterwards. If your patient has had a mastectomy, you typically don't want to use that side of their body to check their blood sugars. You want to use the opposite. So if it was a right mastectomy, then you want to check their blood sugar on the left hand, not the right. Okay.
Isn't that true for most things though? If they've had if they had cancer and lymphatic cancer and they had lymph nodes moved from their legs axillary area, you want to use their right arm for blood pressure and stuff.
Yes. That is absolutely correct. All right. So make sure you go in, do your hand hygiene as normal, assess the skin that you're going to use as a puncture site. So this is what I typically do because sometimes, especially with older people, their hands are super cold and that's not going to get you a whole lot of blood. So I like to go in the room, assess their skin first. And if their hands are very cold, I'll put them underneath their blankets for a little while, let them warm up some. I'll have them rub their hands together just a little bit if I need to, but assess that area so that you know exactly where you can go to get the best amount of blood. So you can only have to poke your patient one time. All right. Make sure you're inspecting those fingers or their forearms for any extra edema because that will give you an altered result. Check and make sure there's no inflammation, there's no cuts or sores. If there's a recently punctured area, so most of the time you can tell where there's been a recently punctured area, but if you can't, you can always ask your patient, where did they poke you the last time? Okay. And if they use the left middle finger, then maybe go to the right middle finger or go to a different finger on the right hand, but do not continue to use the same puncture site all the time. Okay. Let's see. We always want to use the sides of the fingers. And that's like, if you're looking at your hand, if your hand is laying flat, you want to use the sides that you're looking at. You don't want to use the middle of the fingertips because thank you, Miss Johnson. Everybody see that? She's got her finger. She's our model today. So you want to use the sides of your fingers. All right. If you use the middle of the fingers, it can hurt your patient more because there's a lot of nerve endings there. So, we're nurses. We don't want to hurt our patients. So we want to make sure we're choosing the right spot to do our AccuChecks, right? So make sure, like I said, use the side of the finger and don't use the anything that's been recently punctured. So the last time they had their blood sugar checked, like earlier in the day, don't use that same finger. Okay. All right. Make sure your patient understands what we're doing. When you have Alzheimer's patients, sometimes it can be pretty hard to explain to them what they're doing. Sometimes, some of our patients, they're used to it, so they're okay with it. But sometimes you might have a fighter. If your patient fights you or say, no, I'm not having that done right now, don't do it. Right? We know they need to have it done, but I'm not trying to get punched out first thing in the morning. Right? So give them a little bit of time, distract them a little bit, play a little music, put them in a better mood, and then come back and ask them to do it again. Okay. Don't just try to do it just because you need to get your job done. Remember, these are people, they have the right to refuse, but we also know that this is something that's better for their health for us to check. So you just want to make sure that, you're not going to get punched in the face early in the morning. Because I'm telling you right now, some of these Alzheimer's patients, they're real strong and they could pack a punch. So proceed at your own caution. All right. All right. When you're planning your glucose monitoring, make sure that you are, or not make sure, but you want to make sure that the expected outcomes, we want to make sure that the puncture site doesn't continue to bleed or that there's no damage there. Absolutely want to make sure that our blood glucose measurements are accurate. All right. So if you get a number that's out of whack, let's just say you check your patient's blood sugar and it comes out to 602. All right. And you know that, an hour ago, she was 122 and you gave her a unit of insulin. Her blood sugar should not be 600. So the best thing to do in that situation is recheck. Okay. Right. Make sure that your patient can verbalize, or demonstrate their blood glucose measurement. So if you're in a hospital or if this is a new patient that are newly diagnosed diabetic, you want to make sure they know how to do this correctly. Right. So I typically, well, with kids, I have to make sure that mom and dad and anybody else that might be caring for the child that's present knows how to do this and is comfortable doing it. Is one of the worst things that I've seen for parents is to have to poke their child multiple times a day, just with checking their blood sugars and giving their insulins. So before they can go home, we have to make sure that everybody involved is able to do it. Okay, sometimes the kids are okay with doing it themselves, but mostly they're not. So we have to make sure parents and families are comfortable doing it. All right. Make sure your patient knows those results, right? Make sure that they can explain those test results. So, if your blood sugar is 85, make sure your patient understands what to do when their blood sugar is 85. Oh, it's 85, that's normal, right? So I don't need to do anything else. Which, by the way, the normal blood sugar, it's been changing for the last several years. It's always, every couple of years, they'll give us a different number. But 70 to 100, I believe 106 is our target number. It used to be 74 to 118, but now it's changed. So let me just verify. Yeah, 70 to 100, 105, 106, something like that. Excuse me, 74 to 106 is what your book says. All right, 74 to 106, those are our magic numbers. So if your patient is 85, then and your patient knows there's nothing else that we need to do. Blood sugar looks good, okay? But if your blood sugar is 50, your patient needs to know what to do in that position. Or if their blood sugar is, 250, they need to know what to do. So we're there to kind of let them know. And that's something that you guys will learn when you get towards med-surg, right? All right, make sure you do your hand hygiene. If your patient is an adult or a kid, you can also have them wash their hands with soap and water. That's just to make sure we don't introduce any kind of infection or any kind of pathogen into an area that we're about to make a break in their skin. All right, so everybody, hand hygiene. All right, rinse and dry. Okay. Some of these glucometers that we use require a code from the test strip vial to match the actual glucometer. Some of them are still like that, especially when you're in the hospitals and things. But nowadays, when you have to buy your glucometer, most of the time they don't need a code. So when we go into the lab tomorrow, our glucometers don't require a code to match anything. So you can just open the vial of strips and insert one into the glucometer that you're using. Okay. Make sure your glucometer works. Right. So turn it on first. If you don't turn it on first and insert the strip into the meter, sometimes that automatically turns on the machine as well. Okay. Make sure if you open the vial that contains the strips, make sure you close that vial as soon as you remove a strip from it, because you don't want to expose those strips to air, because they can give you false readings if so. So make sure you take your strip out and close the container back. Don't just leave it sitting there open. Try not to bend that strip. Try not to do a whole lot of extra stuff with that strip. Put it into the machine and then do what you need to do. Okay. All right. For those glucometers that require codes, the code on the bottle or inside of the strip container must be used in order for the machine to work. So if you have that type of machine that requires a code, then make sure that the codes match, because if they don't match, then your machine will not work. Right. So then we're going to watch a video for this in just a second, but all of your lancets are single use. Well, not all. I guess there's some multiple use lancets well, not lancets, but the device. So like when I was at home checking my blood sugar, my device was, I mean, it was single use. I've never seen a multiple use lancet device. Have any of you guys? Where your device has multiple lancets to check your blood sugars? I'm gonna take that as a no. I've never seen it before, so I guess they're out there in the universe somewhere. But either way, most of them are single use. So once you use one lancet on your patient to prick their skin, it should be discarded. Like most of them in the hospital, not most, but all of them in the hospital, they won't even, you can't even depress the button to get it to poke you again. You have to use a whole new lancet, right? So they all contain a protective cover on the tip of the lancet to protect that needle from puncturing anything. So you'll take that cover off, all right? And if it's one of the home use ones that, you know, you can adjust the depth of the lancet, then you'll put the cap back on it. If it's just a regular lancet, then you just take the regular cap off, the protective cover off, and then you use it, and then you discard it. And we have both in the lab. I don't have any of the lancets for the home use one, but I do have one so that you can at least see what it looks like. Right. Then you'll want to obtain your blood sample. Where am I at? Obtain your blood sample. Make sure that before you get your blood sample that you wipe the patient's finger or their forearm lightly with an antiseptic swab, like an alcohol wipe, and you allow it to completely dry. Okay, the sugar and alcohol can alter your results. So you need to make sure that that alcohol has completely dried when you do it. Sometimes I'll take with me a sterile gauze when I go to do my blood sugar check so that I can wipe that as well. So I'll clean it with the regular alcohol wipe, and then I'll kind of wipe it with that gauze to get that off. But you can absolutely just wait for it to dry. Wait for the alcohol to dry, because you don't want that to give you a false reading. Oh, where's my chat? Somebody left a message. I'm trying to get to it. That is correct. You are not supposed to fan dry. So that means, you know, if you wipe the skin with alcohol, don't put your other hand on top of it and fan it to dry. All right, because you can get more pathogens and organisms fanned onto the area that you just cleaned. Thank you, Ms. Johnson. All right, so whatever you do, just make sure it's completely dry. Right? Remember, we're going to select the side of the finger like this person's got here, not the pad of the finger or the tip of the finger, but on the side. Okay. Hold that area in a dependent position. So like they've got this finger pointed down, hold that finger down. All right. You want nature to help you here. So that's going to help the blood flow a little better. Okay. Hold that, do not milk or massage the finger side. Okay. Because that could give you some excess tissue fluid, and it's also going to alter your results. Okay. All right. So once you get ready to do, make sure you hold the tip of the lancet device against the side of the finger, which is the best location to do it, or the forearm, depending on your patient. Finger's the best. Okay. And then you'll push whatever button is on your lancet device to puncture the skin. All right. Some devices puncture so well that your blood will automatically start to appear. And then others, you kind of got to work just a little bit. So you can gently squeeze gently until a round drop of blood comes. And then that should be all you need to get your sample. Okay. All right. So this little amount right here is all you need for your sample. As long as you make sure you get it into the little test strip, you're good to go. So I'm going to show you guys a little video real quick.
After performing hand hygiene and ensuring privacy, introduce yourself to the patient. Then identify the patient using 2 identifiers.
Could you tell me your name, please?
Shannon, Gloria.
And what's your date of birth?
4/10/65.
Wonderful. Okay. So the first thing we want to do is just look at your hands and find a good place to do our test.
To perform a blood glucose test, begin by assessing your patient. Note in particular the condition of the skin at possible puncture sites, such as the fingers and forearms. Look for edema, inflammation, cuts, and sores. Avoid bruised areas and open lesions. The patient should be positioned comfortably in a chair or in the semi-Fowler's position in bed.
This one, but before we proceed, I'd like you to just get up and wash your hands for me.
Okay. I have your blood glucose testing equipment that you'll be taking home with you. That I'd like to go over with you. Okay.
Keep in mind that many types of blood glucose meters are available. You must follow the manufacturer's specific instructions for the model you're using. Remove the reagent strip from the vial and tightly reseal the cap. Insert the test strip into the meter, taking care not to bend it. The meter will turn on automatically. Check the code on the vial. Use only the test strips recommended for the glucose meter you're using. Some newer meters don't require a code, and others have a disc or drum that contains 10 or more strips. Then prepare a single or multiple-use lancet device. Remove the cap and insert a new lancet. Twist the protective disc off the tip of the lancet and replace the cap on the device. Then cock it and adjust the puncture depth. Apply clean gloves and select a puncture site in a vascular area. In a stable adult, the lateral side of the finger is usually a good choice. Be sure to avoid the central tip of the finger. It has a denser nerve supply, and pricking the skin there can be painful.
Okay, so what I want to do now is clean the site there on your finger.
Wipe the puncture site lightly with an antiseptic swab. Hold the area of the puncture site in a dependent position. Don't milk or massage it. Hold the tip of the lancet against the skin at the intended puncture site and press the release button. Some devices allow you to see the blood sample forming. Remove the device. If you don't see a drop of blood, gently squeeze or massage the fingertip until a blood drop forms. Make sure the meter is still on and bring the meter with the test strip already in place to the finger.
Just reinsert that there. Looks like we're ready.
The blood will be wicked on to the test strip. Follow the specific instructions for the meter you're using to be sure you obtain an adequate blood sample. The test result will appear on the screen of the meter. Some devices emit a beep when the blood glucose measurement has been made. Now you're all finished. Turn off the meter if your model doesn't turn off automatically. Dispose of the test strip and lancet in the proper receptacles. Then remove and dispose of your gloves and perform hand hygiene. As part of your follow-up care, assess the puncture site for any bleeding. Discuss the test results with the patient and give her a chance to ask questions. If she has been newly diagnosed with diabetes mellitus, encourage her to become an active participant in her own care as soon as she feels ready.
All right, any questions on using the glucometer?
I thought you weren't supposed to milk it.
You're not before you perform the procedure. So before you go to poke your patient, don't massage the finger, because that's going to make all of that extra fluid go down there, and it can give you a false low reading. So, but once you've poked it and you're getting ready to get your sample, just that spot where your blood is coming out is where you can, kind of give a gentle squeeze to get that blood to come all the way out. Make sense? Okay, very good. Oh, hold up. Let me get my life together with my slideshow. All right, so where is the best place to do a to check a blood sugar? Fingertip? Thank you, Miss Brockers, on the side. Absolutely right. So the sides of the fingers are the best place to go, not in the middle because there's a bunch of nerves there and it's going to cause a lot of pain. You can start to get some neuropathies in that point as well. So very good. Thank you, ma'am. All right. All right, so this is the way your, now mind you, in a hospital, sometimes they have the large glucometers. It's like a little, oh gosh, I'm gonna age myself here. Does anybody remember the Palm Pilot from the 90s? No, it's just me. Oh boy. Well, so the, it's like the glucometers in the hospitals are large. They're very big. And they're big because, y'all make me feel old. They're big because you can do multiple people's blood sugars. It can hold all sorts of information. It's like a little computer, and then you can put it in a docking station and it will disperse that information into each person's chart. So it's like a miniature computer that can take your blood sugar. So in the hospital, you're not going to see these teeny tiny ones like this because everything is up to speed on technology. So you're going to really see a much larger glucometer. They work in the same manner, but they can do a whole lot more. Okay. Right. Make sure that you have enough blood on your meters. We've already talked about this part. Once you're done, make sure you turn the meter off. Dispose of the test strip and the lancet in the sharps container. Right. Do your hand hygiene, remove your gloves. I like these videos to show you guys how to perform these skills, but sometimes I feel like they need to do their hand hygiene and put gloves on before touching all this equipment. Like the glucometer is the patient's personal equipment that she used in this last video. So I feel like it's probably a better idea to put on some clean gloves before you start handling her personal equipment. And, you know, you're going to be puncturing the skin. She's punctured her skin beforehand. Who knows if there's blood all over that machine. Bringing me to another point, if you're in a skilled nursing facility or hospital, and you're using a multi-use glucometer, like you're going to use that glucometer on multiple patients, please clean it in between your patients. Right? Don't just use it on patient A and then go use it for patient B and then patient C. Please clean it in between each patient, and so that you're not traveling any germs that one patient may have. Okay. Make sure you're inspecting the site to make sure that it's not going to continue to bleed. All right. And make sure that you get those test results. All right. So whatever the test results are, make sure you record them in the patient's chart and go over that with your patient. And if need be, let the provider know if it's a number that's out of the norm. Okay. All right. So let's see, who am I going to pick on now? Somebody's turn. Miss Momani. Good morning. I know. So you just checked our patient's blood sugar 10 minutes ago, and I'm coming on shift to relieve you because you're trying to go to this party around the corner. So you got to get off work early. So I'm coming in to relieve you. So I need a report on this patient that you just checked their blood sugar on.
You need me to explain the process or?
No. Just tell me what happened with your patient. So what's their blood sugar, how they tolerated the procedure, and if you did anything to fix their blood sugar after you checked it.
Yeah, okay. If I'm gonna give you the report, I'm gonna tell you how the blood sugar was, how the patient tolerated it, and the range of the blood sugar, whether it was low or high, and whether I gave the blood sugar or not.
Okay.
Yeah,
very good. Very good. So very good. See, you guys, don't be scared. Don't be scared. I'm a good nurse to give a report to. Right. So all I need to know whenever you're letting me know what's going on with your patient is, Miss Mamani, I just checked our patient's blood sugar. Blood sugar was make up something here, 275, right? So since their blood sugar is out of the normal range, I did call the doctor because we don't have any orders for the patient's blood sugar being that high. So I called the doctor and, well, I paged the doctor. They have not paged back yet. So please be on standby. Here's my phone so that you can answer whenever he calls back, and just let him know the patient's blood sugar is 275. The patient is complaining of a little bit of a headache, but otherwise she's okay. I'm not giving her anything to eat right now, and she does have some water at her bedside, right? I don't want her to eat more carbs and bring her blood sugar up even more, so I want her to just kind of chill out for a little bit. And like I said, you guys will learn all of this stuff when you get to med-surg. So I'm not really worried about all of the what's and all the things. I just want you to be able to check the blood sugar right now, okay? So does that make sense? Yay, very good, very good. Share your results with the patient if they're alert and awake so that they know what their blood sugars are. Some patients will write it down because they like to see a trend of what they're doing. Some will tell you, oh, my blood sugar is normally not like that, so I don't know what it is. If it's lower than normal, you give orange juice, right? Okay, so that really depends on how low it is, how responsive your patient is, and what your protocol is at your facility. So orange juice will bring your blood sugar up quickly, but it will not sustain it at a good level. So now we've really moved away from only giving orange juice. So my patient's blood sugar is 60 and they're normally like, 90. Then I might give orange juice just a little bit, only 4 ounces will do. Just a little bit of blood or orange juice to bring their blood sugar up immediately, but then I'm going to give them some crackers, some peanut butter, something like that that's going to help sustain their blood sugar at a higher level. Okay, because if I just give orange juice right now, in about an hour, their blood sugar is going to tank again. That help out? But your facility will tell you. Sometimes they have parameters and a protocol that they follow. So just be sure to check with your facility to see what exactly they want you to do in the event that your patient's blood sugar is too low. Okay, great question. Right. Unexpected outcomes. Your patient continues to bleed. What do we do if you puncture your patient's finger and it doesn't stop bleeding? What do we do?
Hold pressure on it?
Yes, absolutely. We want to make sure that we're holding pressure to the site.
And raise it above the heart level?
Absolutely. Raise it above the heart level, apply pressure. And you don't have to stand there the entire time. Like, if you need to discard your materials, chart what you need to chart, you can have your patient, as long as they're able, they can apply pressure themselves. Okay. But you do want to monitor and make sure it stops bleeding at some point. Like I said, if their level is out of the target range, what is the target range for blood glucose level?
70 to 106.
Mm-hmm. If their blood sugar is out of that range, then we want to thank you, ladies, make sure that we are assessing and addressing that accordingly, according to whatever the doctor's orders say. Right? If your glucometer malfunctions, troubleshoot and repeat the test. You may need to go get a different glucometer. All right. But you can't just not check your patient's blood sugar if that's not working. All right. And then once you're done, you can document on your flow sheet or chart it in the computer, or however your system is charted. Determine if your patient has excessive pain, if there's excessive bleeding, and you want to, of course, chart what their blood sugar results were. Okay. When you're handing off, when you're giving that nurse report, let them know what you did for their blood sugar if it was out of their range, right? So if they had hypoglycemia, which means their blood sugar was too low, then you want to address that and say what you did. Okay. Gave 4 ounces of orange juice and crackers and peanut butter. If they're hyperglycemic, then you would medicate them with insulin as per their order says, right? And then you would, of course, if their levels were out of whack and you check them, let's just say, what time is it? At 10:59 at 11 a.m., you want to make sure that you give them whatever you need to give them. So whether it be insulin or you know, the orange juice, crackers, peanut butter, you want to reassess them, okay? So give them about 45 minutes to an hour and go back and recheck their blood sugar, okay? We want to know that the treatment that we gave them actually worked for them. Let's go ahead and take a break and come back at 11:10, and then we get to talk about all the good stuff. 11:11.
Yeah, can we come back at 11:11 since it's such a good number?
Oh my gosh. Yes, guys, come back at 11:11. We're not trying to upset the universe today.
Yes.
That will be fine.
Did everybody make a wish?
No, I missed it.
Oh my gosh, I'm gonna text you at 11:11 tonight because I'm so disappointed.
Okay.
All right, everybody all signed into the chat. I may have not been paying attention to the time. Thank you, Miss Ralph. Bring me back. Sign myself into the chat.
Did you make a wish?
Of course I made a wish.
Hey, there you go.
All right, guys, we're bringing it up on towards the end. I probably will skip some of these last slides because I do have a video for you on the last couple of slides because I do want to be able to tell you a few things about your exam next week. So the slides will be, or they are uploaded into Canvas already. And now that I'm in a better interwebs location, I will upload yesterday's lecture and today's so that you guys have access to them as well. Right. So here we go with bringing up the end of our lecture for today. All right, so now we get to talk about elimination. So now we moved on to chapter 19. So if you're following along in your skills book, that's where we're at now. Make sure everybody sign into the chat for me. All right. So we are going to talk about assisting with the use of a urinal. We'll talk about applying a male incontinence device, which, guys, I'm not really going to talk about it because I feel like that's something that probably better to see instead of me telling you. So I will probably show a video for that one as well. We'll talk about, we're not doing catheters today. And then we'll talk about giving an enema, everybody's favorite. All right, so let's talk about urinary elimination. We all have to do it. It's very important that we do it. And it can be compromised by many illnesses, all right? So typically the way we operate is our bladder gets full and then we go to the bathroom to void, correct? Very good. So sometimes we have to monitor our patient's output as a means to see how their kidneys are functioning and how their body systems are functioning as a whole. So there's some terms that I wanted to bring to your attention, right? These terms right here. When we're talking about urine, you're going to hear these terms a lot. So polyuric, just based on that term, what do you think that means?
Frequent urination.
Yes, it means excessive urination, right? So you went to the bathroom 5 minutes ago and you have to go again right now. And it's not just the frequency, it's just that there's lots of urine coming out each time you go, okay? So polyuric means excessive urination.
But doesn't polyuric have something to do with acid or something?
It could have something to do with many things.
Okay.
But we're not getting into all the ins and outs of that. I just want you to know these terms, okay? I don't want you to get confused or try to study more than you need to for the test, okay?
Okay.
Very good. All right, and then we have oliguric. Oliguric means that you're producing less than 500 mLs of urine in 24 hours, or less than 30 mLs an hour. So the normal adult will produce 30 mLs an hour of urine, all right? And that's something that you guys will learn maybe in A&P, but most definitely when you go to med-surg, that the adult will have 30 mLs per hour output, or should. Okay, so if they are oliguric, then that means they are producing less than 500 mLs in 24 hours. Okay. If they're anuric, anybody have any idea what that means?
Means they're not producing any at all?
Not necessarily no urine, but it means there's less than 250 in 24 hours. So it's close to none. Okay. Anuric is less than 250 mLs in a 24-hour period. Right. What about dysuria? Anybody know what that means?
Painful.
Absolutely. Painful urine. Painful urination. Okay. What about nocturia?
Nighttime.
Nighttime urine. Urinating while you sleep. Pissing in the bed.
Okay, ma'am. Yes, it is urination at night. All right. And then what about urgency? If we hear somebody has increased urgency, what does that mean?
That means they have a hard time holding it, that they feel like they've got to go really bad.
Absolutely. It's that commercial. Gotta go, gotta go, gotta go. Gotta go. Get out my way, right? Very good. Right, so we want to make sure that we're helping our patients to void or urinate. So if we need to, one of the ways that we can do it is stick their hand in fluid, that sometimes that will stimulate, giving them IV fluids at a faster rate, or making them drink more fluids so that we can try to get those, some of those problems resolved, right? Right. So we'll talk about catheters just for a moment, but we're really not going to go into catheters very much. But I do want you to be aware that, in the hospital, we talked about nosocomial infections and the fact that using indwelling catheters on our patients is one of the main reasons why we see those nosocomial infections. Right? But we call them CAUTI, C-A-U-T-I, which means a catheter-associated UTI. We don't like those, right? So, a lot of nurses and a lot of facilities put that aspect of care into the nurse's hands, saying, I need you to determine why this patient needs this catheter, right? And we have a checklist that we go through, and if something isn't adding up right, then we can always ask the provider, can we please remove this Foley catheter? There's no reason for it to be in. Okay, because we do want to reduce the occurrence of CAUTIs. It's very expensive, and it could prove to be deadly for our patients if it got that far. Right? What are some symptoms of UTIs?
Burning, pain.
And older people?
Yes, odor, foul odor, pain, burning upon urination. Increased urgency, increased frequency. fever. Some have blood in the urine.
How about like abdominal or like lower pains, I guess?
Yes, yes. Your kidneys are located in the back, so they may have that lower flank pain as well. They may have pain of where their bladder is located, right? That's lower suprapubic area. Yes, ma'am. Miss Johnson, you're absolutely correct. In older people, this is one of the ways that you can kind of sort of guess maybe my patient has a UTI. In older people, it tends to mess with their minds and they kind of act a little delusional. They might, I don't want to say crazy, but I kind of do. So sometimes they act out of their own character. And one of the first things for older people that we can assess is, do they have a UTI? And a lot of times they do. Very good. So when we're dealing with our catheters, and you guys will learn this skill next semester in the advanced skills class, so I'm not really going to spend a whole lot of time on it, but there are certain things that you need to know if you're taking care of a patient that has a Foley catheter intact. They must be inserted using sterile technique. You gotta have sterile gloves. I mean, you guys all have the kit in your bag, so you know it's a sterile procedure. Right? You need to secure those Foley catheters when you have them inserted. So remember yesterday when we had our patient, we were getting a specimen, a urine specimen from the Foley catheter. You remember that screw that was on his leg that was kind of holding the Foley in place? If you have a patient with a Foley catheter, you should always have one of those stickers on, right? Because we need to make sure that that's anchored so that we don't accidentally move that Foley in and out. Even though it's not going to come out because of the balloon, we still want to make sure it's not moving around. Okay. Should the bag be kind of hanging up by the patient's side? Ms. Ralph said, no, ma'am. Right? If you have a patient with a Foley, their drainage bag should be below the level of the bladder. Right? So if you're ambulating your patient, don't hold it up high. If they're in their wheelchair, don't put it in their lap. Things like that, okay? Right? When you're emptying that drainage bag, and like I said, I'll show you guys this, tomorrow. If you're emptying the bag, so there's a little spigot at the bottom of the bag. You want to make sure that spigot does not touch anything when you're emptying it, okay? And then we want to make sure that we're providing hygiene, pericare for our patients that have Foley. And your facility will mandate how often it should be done. It's usually once a shift. Oh no. Oh no. So okay, so Ms. Johnson says sometimes in older people it makes them, the UTI will make them act a little crazy and delusional. But sometimes some of the aides that are working with these patients with Foleys will have their, oh goodness, their bag up by their head and wonder why the bag's not draining. She also inserted an eye roll there. That's a big eye roll. Because if you think about it,
the worst part about that is not even the fact that they're wondering why it's draining. If they have a UTI, it's because of that. That bacteria is coming back up. So now it's based, like that's on the facility. That's why I hate nursing homes.
Okay, well, I mean, they're not all terrible, but there's sometimes bad workers in them. So we can't blame them.
They're not all terrible, but a vast majority of them do not take care of their patients the way they should.
And you're not wrong.
That one right now. My mom is that one right now. She's doing a travel assignment in North Carolina, and they didn't have any briefs for their patients for the night shift, and they only had one set of like clean linens for the entire floor. So my mom, hit up the DON, and she's like, well, did you message the laundry department? Because that's not my department. I mean, I don't know what you want me to do.
No, ma'am. No, ma'am.
So, it's just,
it's very sad, because that's a part of our population. They've all raised us, right? That's grandma, grandpapa.
Right.
They've raised us, and this is what we do to them.
Right.
In their final hours. And thank you, Ms. Johnson, for being one of the people who want to go in there and make changes and make it better for everybody that's in there. Because we do need nurses like that, I've been in some very nice nursing facilities, and and there's things that I can't even say anything bad with them. The residents are very well loved by all who work there. So, thank you for pointing that out. But anyway, back to Jack here. Make sure with your Foleys that they're below the level of the bladder, because what happens if it's above the level of the bladder, whatever urine is in that tubing is going to reflux back into the bladder, and there's bacteria there, right? And then you've caused your patient a UTI, completely unnecessary, right? So make sure that you're well aware of those things, right? All right, so let's talk about your patients who may need a urinal, right? So we use this whenever your patient can't get to the toilet, right? So if your patient can stand, but they can't go all the way to the bathroom, a urinal is a great tool for you. You just put it at the bedside, your patient can stand, they can go into the urinal, and then they can get back in the bed. They don't have to walk anywhere, they don't have to go anywhere, okay? A lot of times in the hospitals, if your patient is on IV fluids, multiple IV fluids, multiple IVs, Foley, I mean, not a Foley, but, they're connected to a lot of things, oxygen, maybe they have an NG tube to suction, so they can't move a whole lot of places. A urinal is great, okay? So this thing just holds urine. There are female urinals, as you'll notice here, right here. I don't know if anybody else goes camping, but sometimes if you go camping, there's a lovely little device called a shiwi. And it's not really, it doesn't hold the urine, but it's almost like this. So if you're a camper, and like for real camping, not glamping, not like, you in a nice thing and you got running water and stuff. I'm talking about like you have to have a campfire to cook and you're in a tent. These things are great. Anyways, I digress. A regular urine for a male will look like this. Please, guys, if you have a patient that's using a urinal, don't use it for 82 days in a row, okay? They get nasty. Throw them away. We have plenty of urinals. If you can't find anything else in your facility, you can always find a urinal, okay? So be sure to change them out. 24 hours is enough, honestly. Get a new urinal, all right? Rinse them out when they're used and get a new one every 24 hours. Of course, it depends on your facility, whatever they say, but I feel like 24 hours is really pushing it, all right? All right. Your nursing assistant can help your patients whenever they need to use the urinal. Make sure that they know how to help your patient. Check your patient's mobility, and make sure that they can move around enough to be able to use it. Please make sure that they provide personal hygiene after urination. So if they need help with pericare, then please have your CNAs to help them with that. And make sure your CNA knows how to report any changes in urine color, the clarity. So if your patient's urine becomes cloudy, make sure your CNA can report that to you. Or if it becomes odorous, they should report that. If your patient all of a sudden becomes incontinent, they need to let you know, all right? Any of those signs and symptoms of a UTI that your patient may have, your CNA should be able to let you know these things as well, okay? You're gonna need a urinal. Please put on some clean gloves, all right? Most urinals they're graduated on the side so they can tell you how much urine is in the bottle once your patient's done using it. So you typically don't need an extra cylinder to measure. It's typically on the urinal itself, right? If you need to test any urine, if you need a urine sample, please have your supplies for that. And then just something for personal, for pericare afterwards. And toilet tissue, okay? Right, if your patient is getting ready to use a urinal, please assess their fall risk. If they're at risk for falls, they probably don't even need to get out of the bed, all right? Assess their normal urinary elimination habits, all right? If they have any episodes of incontinence, things like that, you need to make sure that you know these things beforehand. Please assist your patient, but if they don't need help, please don't assist your patient because that's awfully awkward. If your patient's going to urinate and you're trying to help them and they don't need your help. So please assess that first. All right. If you need a urine specimen, please know before your patient starts to urinate or before you discard the urine that they have given you. All right. Make sure that you've given your patient privacy. So close the door, close the curtain. All right. The best position is for them to be in an upright position. So if they can stand up, have them stand up. If not, sometimes kind of laying to the side a little bit will help the urine to flow into the urinal the best. All right. All right. Make sure that you are, after the patient has voided, please assess the characteristics of the urine. If you're having to chart I's and O's, your patient's intake and output, please make sure you make a mental note of how much urine is in the urinal so that you can chart that. Make sure you chart if need be. If there's any abnormalities is when you'll really want to chart. If the patient's urine is normal, then typically you don't chart anything. But if it's abnormal, if there's an odor, if it's cloudy, if it's, brown, any of those things, you make sure you want to chart those. Right? Once you're done, once your patient's done and you're going to discard the urine into the toilet, please rinse it out. There is a, I don't know if they have it in nursing homes and things too, but in the hospitals, we have a spigot that comes down from the toilet that you can rinse things out with. So if your facility has one of those, please use it and rinse out don't do it in the sink because, people wash their hands, brush their teeth and things in the sink. Thank you, Ms. Johnson. Can you just let her know that it's just to try to keep getting in? If not, then this will be uploaded soon. Thank you. All right. Let's see. Where was I? Oh yeah. So please rinse out the urinal. All right. Don't just empty the urine out of it and then sit it somewhere to dry, and then hand it to the patient so that they can go urinate in it again. That's kind of gross. Right. And then you're going to document after you've done washing your hands, make sure the patient's low enough, make sure that you document that, okay? All right, so now we're going to talk about applying a male incontinence device. Well, I'll just talk briefly about it, and then I'm going to show a video on how to apply it. All right, so these are non-invasive, means it doesn't invade the body, right? So this is a way to contain the urine who may have some incomplete or some spontaneous bladder emptying. So they may be a tad bit incontinent, but this is a way to help them to continue to be mobile without that worry and without having to wear a brief and things like that, okay? So this is called a condom catheter. It can also be called a penile sheath or a Texas catheter, right? It's soft, it's pliable, it's like a condom, fits over the penis and provides a safe, non-invasive way that will contain the urine for men who have some sort of bladder emptying problems, okay? They're clear so that you can visualize the skin underneath, all right? And they still have latex condom catheters available, so be sure that you assess if your patient has any latex allergies beforehand, all right? These, excuse me. They're held in place by a adhesive coating. Yes, ma'am, they are. They're very difficult to put on sometimes. But they have an adhesive coating on them. So you please do not use tape to keep them in place. All right. Please do not use tape because, over time tape can get tighter and that's probably not the best of things to happen in that area of the body.
I'm sorry, are we talking about a condom cath?
Yes, ma'am.
Okay.
So these can also drain into a drainage bag. So your patient may have one that's kind of taped to their leg, like a leg bag, urinary drainage bag, so that they can put it on and still put their clothes on and go about their business. Or they could use a large volume drainage bag, which would be more of the one that hangs at the bedside, like the normal one that you see that's attached to a Foley catheter. Right? All right, you can delegate this to your CNA. They can apply the condom catheter, but you need to make sure that they know, verify that there's no latex allergies. They need to know how to put this device on and how to secure it. They need to know, okay, no extra tape, right? They need to know these things. Making sure that we're monitoring I's and O's for the patient. And they also need to know if they need to report any redness, any swelling, any skin irritations or breakdown of the glans penis or the penile shaft, they need to know to be able to report that to you. Also, if it causes the patient pain, they need to report it to you. So it can be delegated out to your CNA, but you just need to ensure that they know what is to be delegated, right? So I'm going to show a short video so that we can save ourselves some slides. Be careful with your nails because you can break this. Yes, you can. So this is one of the reasons why we like short nails. Also, be sure you put your gloves on, of course. But you can break the patient's skin when you're putting them on. So make sure that you're being careful with that. All right. Good, this shouldn't take too long. Can you guys see my screen? Okay.
An external urinary catheter or condom catheter is an option for some men with urinary incontinence. After performing hand hygiene, provide privacy by closing the door and drawing the bedside curtain. Introduce yourself and verify the orders.
Today, I understand we're going to be applying a condom catheter. Let me just check your orders real quick, okay? Okay.
Next, identify the patient using 2 identifiers.
Okay, can you tell me your first and last name and your date of birth, please?
Curtis Brinkman, May 9, 1950.
Okay, let me get my supplies and then we'll get started, okay?
Okay.
Raise the bed to a comfortable working height.
Okay.
How are you feeling today?
Okay.
Okay.
And lower the rail on your side.
Lower this rail.
Assist your patient into a supine or sitting position and drape a bath blanket over him.
Let me get some gloves.
Apply gloves and prepare the urinary drainage collection bag. Clamp off the drainage bag port and place the bag nearby, ready to attach to the catheter after you apply it. Now perform perineal care. As you proceed, assess the skin of the penis for rashes, erythema, and open areas. Dry the penis thoroughly. If your patient is uncircumcised, return the foreskin to its normal position before applying the catheter, and do not use a barrier cream. Some condom catheters come with a skin preparation solution and a hair guard that is placed over the penis before applying the device. Refer to the manufacturer's instructions. An alternative to applying a hair guard is to cut or tear a hole in a paper towel and slip it over the penis. Be sure to remove the paper towel after the condom catheter is in place. If necessary, clip the hair at the base of the penis. Otherwise, it may be pulled by the catheter or get caught in the adhesive. Apply the condom catheter using your non-dominant hand to grasp the shaft of the penis. With your dominant hand, hold the rolled condom sheath at the tip of the penis, with the head of the penis in the cone, and roll down the sheath. Allow 2.5 to 5 centimeters or 1 to 2 inches between the tip of the glans and the end of the condom catheter. If you're using a self-adhesive catheter, apply gentle pressure for 10 to 15 seconds to secure it. If the device is secured with an outer adhesive strip, use it to spiral wrap the penile shaft. This elastic strip should not overlap, and it should be snug, not tight. Connect the condom catheter to the drainage bag. Make sure the condom isn't twisted. Secure catheter tubing, leaving some slack in the catheter for movement, to the patient's inner thigh with a stat lock or other device. Coil any excess tubing on the bed and secure it to the bottom sheet. If your patient needs a leg bag, connect one end of the tubing to the condom catheter and the other end to the leg bag. Then attach the bag to him with the leg straps. Now, help the patient into a safe, comfortable position. Lower the bed and adjust the side rails. Dispose of all contaminated supplies, including the bath blanket. Remove your gloves and perform hand hygiene. As part of your follow-up care, assess the penis within 15 to 30 minutes of applying the catheter. Note any swelling or discoloration, and ask the patient if he's having any discomfort. Reapply the catheter daily, unless it's an extended wear device. Reassess the skin of the penis at least once a day when performing hygiene or changing the catheter. When removing the condom catheter, gently roll off the catheter and wash the penis with warm, soapy water. Perform hand hygiene and document and report the procedure.
All right, any questions with applying the condom catheter? Very good. This video made it look very easy, but it can be a little challenging sometimes to get them on. So just beware if that's the case for your patient. Make sure you chart it when you're done. And like she said, make sure that you go back and reassess the patient about 15 minutes after you put it on to make sure it's not too tight, to make sure there's no discoloration. And because if there is, you need to take it off, okay? Make sure you report off to the next nurse saying what you did. Patient is wearing condom catheter. I just put it on about an hour ago, so maybe reassess and ensure that it's not too tight, that there's no discoloration, no swelling, no pain, or anything like that, all right? And that it's draining urine properly, clear yellow urine, all right? All right, so now I'm gonna skip a few slides because we just went through all of that. How much room should we have between the tip of the penis to the end of the condom catheter?
Was it 2.5 inches?
2.5 centimeters. So about 1 to 2 inches of space in between the penis and the end of the condom catheter, okay? All right, hold on, I'm fast forwarding so we can go to where I needed to go to. All right, so now we're gonna talk about a bladder scanner, super quick. You may not, has anybody ever used, oh, hold on, I'm on here. I forgot to bring you guys with me. Let me share my screen. There we go. Has anybody ever used a bladder scanner before? No? They're not hard to use at all. They're pretty self-explanatory. Most of them, when you're in a facility, will still have the instructions kind of taped to them so that you can see really what's going on. But this is very non-invasive. It's portable. It's like a 3D device that will create an ultrasound image of your bladder so that you can measure how much urine is there. So if you have a patient who's unable to void or a patient who continuously voids, you can see how much residual urine is left in the bladder, okay? A lot of times after removing catheters, we might need to check if our patient is unable to void. If anyone's had surgery, if they've had a spinal or some sort of anesthetic, we need to make sure that they're, that their bladder isn't full, or if it is full, we need to see that so that we can act appropriately. The use of these can avoid unnecessary catheterizations, right? So if your patient has avoided in like 5 hours, then, a lot of us might get worried and say, oh, they need an in and out catheter done so that we can get the urine out. But we may do a bladder scanner and there just might not be that much urine built up, so the patient hasn't needed to void. Okay. So to measure the post-void residual that we want to see, the PVR, you would wait 5 to 15 minutes after the patient has voided. Any volume that's less than 50 mLs is normal, okay? So just you and I walking around after we voided, it's normal to have about 50 mLs or less of urine left in our bladder, right? But if we have a patient whose PVR, whose post-void residual is greater than 100 mLs, then we need to investigate a little further, and the doctor will probably determine how to do that, okay? How to go forward with that. You can delegate the skill to your nursing assistant, but you need to know that they know how to work the machine. So as long as they can work the machine properly, then they are more than welcome to go ahead and do it. Let them know that they should wait 5 to 15 minutes after the patient has voided to be able to use the machine. And they need to record or report those volumes after they've than the bladder scanner. So it usually will print out whatever is left in the patient's bladder for you, okay? And you just need to chart it or document it. All right, so identify your patient, check out their eyes and O's. You know, you want to see how much they've been voiding. Make sure the patient is lying flat and supine. You can raise the head of the bed if they're not comfortable with lying supine, but they should be lying flat, as flat as possible, right? So this is almost like doing an ultrasound when you have a pregnant mother, except you're not assessing for a baby, you're assessing the bladder, okay? So you're gonna need to expose the patient's lower abdomen. You'll turn that scanner on and set a gender designation. That's very important because anatomically, females have other things in the lower abdominal region. So we need to know what we're looking at before we do that. So you can set it to male or female. If you have a female patient who has had a hysterectomy, then you will set her setting to male. Okay, because all those structures, the uterus and all the things, they're not there to be in the way or add to the bladder, right? So you're going to use gel anytime you use an ultrasound, any kind of scanner like that. So you'll use some gel. Typically it's warmed for the patient, so it's not just cold. And then you're going to put the scanner onto the suprapubic area, and you're going to put a little bit of pressure there. Okay. Keep the scanner head steady, point it downward towards the bladder. You'll press and release the scan button, and then it's done. Super easy, right? Once you're done, please take the gel off the patient, all right? Make them comfortable, get them clean the scanner head, and then report your results, okay? All right, if the results are more than 100 and it's been more than 100 for a while, then your doctor might order for them to have a catheter, indwelling catheter, or in and out straight catheter is what they're called. If we just put one in and take it right back out just to get the urine off, they may order that. Okay. Moving along, let's go to bowel elimination and gastric decompression. This is going into chapter 20. So we'll talk about putting your patient on the bedpan and giving an enema, and also doing a what's it called? A regular Fleet's enema, which is in the little bottle, and then a like a substance enema, cleansing enema that is given. It looks like an IV bag, but it's not for an IV. So we'll talk about those things. This is chapter 20, and we're not covering all of chapter 20. It's just a few things. Okay. Right. We need to make sure that our patients are eliminating their bowel waste products often, or as often as necessary for that patient. Everybody's not the same. Some people go once every couple days. Some people go every day. Some people go multiple times a day, right? So just know what's normal for your patient at that time, right? Gastric decompression. This helps to keep the stomach empty and will reduce nausea and vomiting when your patient undergoes surgery. So sometimes this is needed, and this is where I kind of showed you guys last week, where if we put the NG tube in and we hook it up to suction, we're decompressing the stomach because we don't want our patient to have nausea and vomiting, right? There's a buildup of all the gastric juices in their stomach, and it makes them nauseous, it makes them want to vomit, and we don't want that to happen for them. Okay. All right, so we might put our patients on some sort of bowel training schedule if they have some sort of neurological disorders, like if you have a patient who is paraplegic, cannot feel the lower half of their body, then they may need to be on a bowel training schedule. And that just means that at 3 p.m. every day, we're going to give them either an enema or a laxative or something to help them go poop at that time, okay? If you have a patient that's on any sort of cardiac disease, has a cardiac disease, or they're taking any kind of cardiac or hypertensive medications, please check their pulses before giving an enema, right? They can vagal out once we stimulate that, that nerve, and they can have a drop in their blood pressure, a drop in their pulse, and they may faint while they're on the bedpan or the commode or the toilet. And then that's a patient fall in a very compromising position, all right? So, and they could get a serious injury from that way. If your patient self-administers their enemas, please don't let them do it while they're on the toilet because you can accidentally um, give an abrasion to your to the lining of the rectum. Okay, so if they self-administer, and you have many paraplegics that are pretty well functioning, they may do their own. So just make sure that they're in the side lying position. Okay. And I know y'all all remember, if your patient's getting an NG2 for decompression, they must be up in the Fowler's position. Okay. Right. Anybody ever used a bedpan? They're not fun. Okay. Not even gonna lie. It's kind of hard sometimes to put your patients on the bedpan. I have a funny story, and I might tell y'all tomorrow while we're in the lab because I don't have time today. You have two types. You have a regular bedpan, which is like this one, the blue one on the left, and then you have a fracture pan, which is the green one on the right. This one is narrow, and it's suited for people who have had hip surgeries. If they're not able to lift up their bottoms or their hips well, this one is better suited to sliding underneath. Okay. You can delegate this to your CNA, all right? But make sure that they know those mobility restrictions and make sure that they know where any wound drains or IV catheters, anything like that, make sure they know that where they're located so that they don't accidentally take them out. Make sure that your CNA provides pericare and hand hygiene for the patient if they're using a bedpan, all right? Because that's kind of gross if you have your patient go poop on a bedpan and you don't wash their hands, right? One of the tips that I got from someone once upon a time, especially when using, not necessarily for using the bedpan because it's not big enough, but if you have a patient using a bedside commode, to put the blue pad or the chucks at the bottom, and it helps clean up much better. All right. So you're going to need all the things. Please make sure you take some sort of waterproof pad with you if your patient is getting on the bedpan so that you can save your sheets and you don't have to change your sheets also at the same time. Make sure you have some sort of toilet tissues or some sort of wipes, some pre-moisturized wipes that you can clean them with. If you need a specimen, make sure you get your specimen container. Please wear gloves. Okay. All right. Make sure you're checking out the patient's normal bowel elimination patterns. Before you do this, make sure that you determine their level of mobility because, like I said, they're going to need to turn over a little bit for you to be able to put the bedpan there. Okay. This is a great time to do an inspection of their perineal skin. So you can check for any redness, any areas of breakdown, skin irritations, things like that. So this is a great time for assessment. This last one says prepare a metal bedpan using warm water. I haven't seen a metal bedpan since ever. Okay, so hopefully there aren't any circulating around, but if you do happen to have one at the facility you're working at, please warm it up with warm water. Okay, because that's, it's going to be pretty cold and uncomfortable for your patient. Make sure that you've given your patient privacy. Close the door, close the curtain. If you have some sort of poopery, give some to your patient. Sometimes the facility will have some sort of room freshener that's not really a freshener. It smells kind of like baby powder, but kind of not. And you can give that to the patient as well, and they can spray if they want to. All right. So you're going to raise the side rail on the opposite side, put the bed to your height, make sure you're not bending over, right? Get the patient into a supine position, all right? And then you're going to help them onto the bedpan, all right? If they're using a fracture pan, you're just gonna kind of slip it under the patient as their hips are raised just a little bit, right? You're going to try to stay as anatomically correct as you can. It's very difficult, or it would be very difficult to defecate lying down, like lying flat. So make sure you raise the patient's bed as much as they can tolerate while they're on there. Right, so raise the head of the bed 30 to 60 degrees for patient comfort. Right, and this is the way that you're going to put the bedpan on. You'll have them turn over. The wide part goes closest to their lower back, and then the smaller, narrow part goes towards their legs. Okay. You'll have them roll over. You'll kind of push the pan there, and then have them roll back over onto their backs. Okay. Once you're done putting them on the bedpan, please put the side roll up and then make sure the bed's in the lowest position. You don't have to leave the room, but it's a good idea to stay like somewhere close by. So sometimes I'll step outside the door and they can let me know that they're done. Sometimes I'll step on the other side of the curtain, do some charting, whatever I need to do, but stay close in case your patient needs you, okay? If your patient is, a walkie-talkie, well, not a walkie, but a talkie, and they can tell you when they're all done, then you can give them their call light and then tell them, hey, I'm just going to be a call away whenever you're done, just to give them that extra bit of privacy. Okay. All right. Once you're done, make sure you document I's and O's, the consistency of the poop, especially if there's been any problems with constipation or diarrhea. So you'll want to make sure that you document that. Wash your hands, clean out the receptacle that they have gone into, and then document, make your patient comfortable. You're good to go. All right. We did that already. Let's go here. I'm not going to a quick quiz today. Now let's talk about enemas. Everybody's favorite. The purpose of an enema is to instill some solution into the rectum and into the sigmoid colon, and it will promote defecation by stimulating the peristalsis there. All right, so this is really helpful in treating constipation. It is also good to empty the bowels before any diagnostic procedures like colonoscopies or any abdominal surgery that your patient may have, all right? If we're using a cleansing enema, then that's gonna help get the feces out of the colon. Okay. Right. You can delegate this to the CNA as long as they understand exactly how this works, exactly how to give this medication, because it is a medication, it must be ordered. And as long as they know to inform you, the nurse, of any cramping, any rectal bleeding, or any new abdominal pain, all right? Sometimes cramping is normal when they're getting enemas, so that might be to be expected. But if your patient has any other problems with abdominal pain, then they need to be able to report it. Also, if there's any changes in their vital signs, your patient's vital signs. All right. In here, I'm going to insert video because me telling you doesn't really do a whole lot. So I will do that. Can I have a few extra minutes of your time so that I can give you the list of what's on your exam next week? Well, not the entire list, but I can help you out a little bit.
Yes, you can have our time for that. Yep.
What time do y'all start for Miss Jackie?
12:30.
12:30. All right, I'm gonna go. I'll try to keep it less than 10 more minutes for you guys, but I'll ask her if you can start a little later with her class so that she can get, you can get your full lunch break. Okay.
Will they count against me if I leave out right now? Because I got a draft to work.
No, go ahead. This will be fun.
Okay. Thank you.
You're welcome. I muted myself, guys. Sorry about that. I'm just talking. Sorry. This video is going to show you both how to give a cleansing enema with like a soap suds enema and also a Fleets enema. All right. And we do have those in the lab. No, we're not going to demonstrate on each other, but we do have them in the lab for your enjoyment.
An enema can be used to treat constipation or to prepare the bowel for certain procedures. Before you administer an enema, introduce yourself to the patient. Note the patient's name, the type of enema ordered, and the time of administration. Compare the record against the label on the enema solution or package. If the enema is medicated, check the accuracy and completeness of the medication administration record against the healthcare provider's order. Then identify the patient using 2 identifiers.
All right, if you could state your name for me, please.
Duana Hankins. And your birthday.
7/4/70.
Okay, I'm going to close the curtain for privacy for us.
Provide privacy by drawing the bedside curtain or closing the door. Raise the bed to a comfortable working height. Ensure that the side rail on her left side is raised.
Then I'd like to assist you on your left side, please, okay?
Help her into the left side lying or Sims position with her right knee flexed. Explain to her that she'll need to stay in this position until the procedure is complete. Cover her with a bath blanket, making sure that only the anal area is exposed. Next, apply clean gloves. Place a bedpan or bedside commode in an easily accessible position. If the patient will be using the toilet to expel the contents of the enema, make sure the bathroom remains unoccupied and keep the patient's slippers and robe handy. To administer a prepackaged, disposable enema, remove the plastic cap. If necessary, apply a little more water-soluble gel to the pre-lubricated tip. Ensure that there is a waterproof pad, absorbent side up, under the patient's hips and buttocks. Now, separate the buttocks and inspect the perianal area for abnormalities, such as hemorrhoids, anal fissures, and rectal prolapse. Gently separate the patient's buttocks and locate the anus. Help her relax by coaching her to breathe slowly in and out through her mouth. After expelling any air from the enema container, gently insert the lubricated tip into the anal canal, angling it toward the umbilicus. Adjust the insertion depth based on the patient's age. In any patient, don't force the tip if you feel.
Sorry, I saw a notebook moving, so I wanted to make sure
Depth based on the patient.
you guys are able to write that down. And right now, we're only concerned with the adult. We'll talk about PD when we get there in third semester. So just know for adult, it's 7.5 to 10 centimeters or 3 to 4 inches. All right. Do not force the tip. And the Sleets enema container is very pliable. So you don't have to worry about it, being hard or anything to get the air out of there first. It's very pliable, very easy to use. Okay. So 7.5 to 10 centimeters, which is 3 to 4 inches, is the enema tip insertion depth. All right.
Age. In any patient, don't force the tip if you feel resistance. Stop the procedure and notify the healthcare provider. Once you've inserted the lubricated tip to the proper depth, roll the plastic bottle from the bottom to the tip until all the solution has been instilled into the patient's rectum and colon. When you're finished, press a few layers of toilet tissue around the rectal tube at the anus and gently withdraw the tube and tip. Discard the enema container in the proper receptacle. Instruct the patient to retain the solution until she has the urge to defecate, which usually occurs in 2 to 5 minutes. To administer an enema using an enema bag, fill the bag with warm water from the faucet as prescribed. If saline has been ordered, warm the container of saline in a basin of water before you add it to the water in the enema bag. Then check the temperature of the solution by pouring a few drops on your wrist. The water should be warm but not hot. If a soap suds enema has been...
I'm pausing just to let you guys know the reason for warming up the solution first is because it can cause cramping, and it's very uncomfortable for the patient if you put cold water, do a cold water enema. So make sure you warm up the water first, or saline if that's what you're using.
Ordered, add Castile soap after the water is placed in the enema bag. Next, raise the bag, release the clamp, and let the solution flow just until it fills the tubing to push the air out of it. Then reclamp the tubing. When the enema and the patient have been prepared, you may apply a little more water-soluble gel to the pre-lubricated tip. Then gently separate the patient's buttocks and locate the anus. You can help him relax by reminding him to take deep, slow breaths through his mouth.
Can you take a few deep, slow breaths through your mouth?
Touch the skin next to the patient's anus with the tip of the rectal tube. Then gradually insert it into the anal canal, angling it toward the patient's umbilicus. As you would for a prepackaged enema, adjust the insertion depth based on the patient's age, but don't force it. As you hold the tube in place, open the regulating clamp and allow the solution to enter. Keep the enema container at the level of the patient's hips to prevent the solution from flowing out of the bag too quickly. Gradually raise the container above the anus. For a high enema, raise it 12 to 18 inches, or 30 to 45 centimeters. For a regular enema,
just pause so that you guys can see the height. High enema, 12 to 18 inches. And a regular enema is 12 inches.
And we'll go over this again, right?
Yeah, we'll go over it tomorrow during lab.
Okay.
Mm-hmm. Right.
My pen just ran out of ink and I didn't want to run away and then you start playing it. So that's why I asked.
Versus get your pen together, man.
raise it 12 inches, or about 30 centimeters. And for a low enema, raise it 3 inches, or 7.5 centimeters. Once the flow of the fluid has been established, you may hang the enema bag from an IV pole. If the patient has cramping, or if fluid escapes around the rectal tube, lower the container or close the clamp. When all the solution has been instilled,
so lowering the container will slow down the flow rate. All right, so it'll make it go slower so that the patient shouldn't have any more cramping after that happens. All right.
Clamp the tube. Tell your patient that you've completed the procedure. Place toilet tissue around the tube at the anus and gently withdraw the rectal tube and tip. For either type of enema, explain that mild bloating and abdominal cramping afterward is normal. Ask her to retain the solution for as long as possible while lying on her side in bed. Stay at the bedside, and when the patient is ready, help her onto the commode or bedpan.
All right, I'm going to stop sharing there. I mean, we know what to do afterwards. Once the enema works, it's pretty much an explosion from there. All right, so be ready. Tell the patient to be ready. Have this bedside commode ready or have the door to the bathroom open, and make sure that they have on their non-slip socks and let them have at it. Right. So make sure when your patient, if you're giving them any kind of enema, they need to be in the left side Sims position. So they need to be lying on their left side in the Sims position with that right leg slightly bent. All right. And make sure that if your patient starts to cramp while this enema is infusing, that you lower the height of the infusion to slow the infusion down. All right. Any questions there? All right. Alrighty then. So grab your pen and paper. And I'm going to tell you some of the things that you can focus on. Obviously, I'm not going to tell you specifics, but I can tell you some of the things to focus on. Remembering that anything that we have covered in these last 4 weeks is fair game for your test. Sorry, I thought I had a copy of something. I could tell you exactly what chapters are going to be on this test. It's on your course lesson plan, your course calendar. It's either in Canvas or your binder that we gave you at the very beginning. So if you want to look to see the specific chapters that are included on this exam, please look on there. And I'll tell you tomorrow because I don't have it pulled up right now and I don't want to waste any more time. I haven't heard back from Miss Jackie yet, so I don't want to take away your lunch break. All right. So urine specimen collection. Make sure you know all things related to it. You know, we talked about the different kinds, the 24-hour time, the clean catch, and urine from an indwelling catheter. So know all of those. Know about giving your complete bed bath to your patients, right? Including those who have any vascular issues and those who have diabetes. And remember, I'll post this as well. So in case you miss out on something, it'll be posted. Review your denture and oral care. for your patients?
We did dental care?
Yes, we did. You may not have been there that day.
Oh, okay. Okay, that makes sense.
So denture and oral care, hair and nail care. Last week we talked about nutrition, so be familiar with the different diets that we talked about, like clear liquid diets, full liquid diets, soft diets, things like that, and know what kind of foods are supposed to be given with those diets. We talked about transferring your patients. As in like moving your patient from one spot to another. Helping your patient ambulate with crutches. Everyone's favorite. Oh, here, let me slow down. Sorry, guys. All right, everyone's favorite stool specimen collection. Be familiar with all of those urinary terms that I just went over. Right. Giving enemas. Review patient falls. Review suctioning your patient. And also review your patient who is on home oxygen. Review that as well. All right, once again, this is not all inclusive of what's on your exam, so please be sure to go back and listen to those lectures that we've had. This is not a comprehensive exam for next week. This is just an exam. So this is not like a midterm that's going to have everything we've learned so far. This is just from what we learned the last exam to now. All right. Anybody have any questions? Do I need to repeat anything for anybody?
Are you gonna post the recording?
Yes, ma'am. I will post the recording for both today and yesterday. I'm actually going to do it right now.
Okay, thank you.
You bet. All right, guys, if there's no further questions, make sure you come on time for your clinical time tomorrow. If you need to come early, come early. I will be there first thing in the morning. And study well for your midterms and things next week. And so, sorry, guys, for taking some of your lunch break. Be with Miss Jackie for 12:30, okay? All righty. Thank you for your time. I'll see y'all tomorrow.
Thank you.
Have a good day, guys.